uh, in the country, probably in the world also here at the same stage. So it's very nice to see all of them. We're going to have some very interesting discussion on a new selective JAK1 inhibitor that is being introduced into our country, upadacitinib. I think upadacitinib is making a lot of difference. Even for non-IBD specialists like me, it's quite an exciting news that some of our patients can now be changed from a biologic into a oral tablet like upadacitinib. There are several advantages of this. It's rapid onset, short half time, and of course, I think lack of immunogenicity and monotherapy. All these are, I think, advantages of this. We also have a lower cost compared to Western world, and I think this is very important that we are now starting to get this easily available so that it can be integrated into clinical practice. So to introduce this molecule, to discuss about this molecule, we are now going to have this panel discussion. And as I said, I'd like to welcome all our panelists, Dr. Vishal Sharma from PGI, Dr. Ajit Sood from Ludhiana, Dr. Matthew Phillips from Kerala, Naresh Bhatt from Bangalore, Kiran Peddi, Hyderabad. We have Anurag Jena from Cuttack, or now it's Anurag is, of course, Orissa, Ajay Kumar, Delhi, Usha Datta from PGI, Arshdeep from Ludhiana, Partapal from AIG, and Rupa Banerjee from AIG. So we have a very strong IBD team, and all of them are going to now discuss on various aspects of how this molecule can be used. So basically, we are going to have first an initial introduction by Dr. Rupa Banerjee, followed by a case discussion by Vishal on a panel of course of these very eminent people we already discussed. They're going to discuss this. And then the second case is going to be Anurag Jina on ulcerative colitis. Again, another panel we're going to have. And of course, finally, Rupa is going to integrate all this into clinical practice. So I think we'll start first with Rupa. Rupa, you can start with your session.
Thank you, sir. I think, yes, for IBD, it is exciting times because we do have the generics of upadacitinib now available in India, and it's an oral therapy. But today we are going to get into how it is being used for Crohn's disease, for ulcerative colitis, and then also how what are the precautions that we need to take, how we can use it, when we can use it. And I think we have the leaders, top leaders of the country as panelists. So it is really going to be exciting. Without much ado, let me just introduce the first case. Is going to be Crohn's conundrum, how to deal with it. And the presentation is by Dr. Vishal Sharma, who actually does not need any introduction. He is the associate professor from PGI Chandigarh. And Vishal, it's just over to you to introduce the panelists and begin the first case.
Thank you, ma'am, for the kind words of introduction. I'd like to thank Mr. Reddy and Dr. Rupa Banerjee for asking us to do this panel. I hope my slides are visible.
Yes, Vishal.
Thank you. So as you can see that we have a very eminent panelists. We have Professor Ajit Sood, Professor Matthew Phillips, Professor Naresh Bhatt, and Professor Kiran Peddi. And without wasting much time, I'll just start off with the case because I think we have some ground to cover in the limited time. So the story begins in April 2022. This is the time when we did not have access to upadacitinib in India. So Mrs. HK, a 46-year-old female, developed pain abdomen, which was periumbilical. It was crampy and relatively mild and was relieved with analgesics. And as is usual, she took some over-the-counter medication with symptomatic relief and obviously was not investigated at that time. She seemed to improve, but a month later, she also developed upper abdominal pain. Now, this was associated with some amount of loose stools, which were 2 to 3 episodes per day. There was no blood, no nocturnal symptoms, and no rectal symptoms. So I'll go directly to Professor Sood. I mean, this is very limited information, but how would you kind of approach this at this stage?
Right. Thank you, Vishal. I think this lady, middle-aged lady, has pain abdomen. We started perimbrical and involved epigastrium and has increased frequency of stools. I think in a country, initially we think of infections, and that's what I will consider infections like amoebic or giardiasis or these things. And of course, I would like to get an ultrasound also to rule out biliary pain. But I will consider more of infections rather than any chronic disease at this moment.
So she
Vishal,
now
just a point that I wanted to make, because how important is pain in a lot of these infections, say, apart from tuberculosis, these other things, is pain a very important thing? What's the message that we want to give our people? Because we sometimes underestimate the pain that we see in some of these conditions is there, but does it always mean inflammatory? That's the point I was trying to bring out.
Yeah, I mean, that's an important point that you make, that while with, I mean, florid diarrhea, there may be some amount of pain which can happen in infections, but persisting over this period of time, maybe beginning off as, pain, relatively would be uncommon. Certainly with TB, pain is an important thing. I think Dr. Matthew Philip wants to just say something here.
The timeline is very important. No, anything lasting for more than 4 weeks, I think we should be giving a little more importance. I agree that what Professor Sood is thinking about is that because infections are so common, so rampant, so we need to think about that. But depending upon the regional variations, I think, if this patient is in my practice, my first thought would go for IBD because of the time period of more than 4 weeks of that. I agree that infections are quite important in this in Indian scenario.
I think we agree that we would have a broad list of differentials, including IBD and possibly some of the infections. And a colonoscopy was done at this stage. Multiple discrete non-confluent ulcers were noted in multiple areas in colon, and somebody actually noted that there was a cobblestone appearance with normal intervening mucosa between the ulcers. The biopsy was focal active colitis, no granuloma, AFB was negative, and gene expert was negative. So again, now I will again go to Professor Sood. So Sood sir, I think things are much clearer now.
Yeah, I think with this colonoscopy, with the showing involvement of the left colon and their confluent deep discrete ulcers, and there's negative gene export, and there's no exposure to tuberculosis. So if you think of various causes now with pain abdomen and left-sided active colitis, I think IBD does become one of the major contenders, and IBD is a possibility. I'll come to that between Crohn's versus UC, and other possibilities which we have to keep it in mind are vasculitis and ansated nevus, but in this lady, there's no history of ansads. And for ischemic colitis, she's relatively young to develop ischemic colitis. So I think if we think realistically, possibility of tuberculosis is less. NSAIDs, there's no exposure. Tuberculosis, there's no exposure. Gene export is negative. So it comes to a left-sided colitis, and IBD becomes a possibility. Between IBD, I think Crohn's and UC both we have to discuss. And important point to differentiate here will be is more in favor of Crohn's because ulcers in ulcerative colitis, whenever there are ulcers in ulcerative colitis, the ulcers are always merged in inflamed mucosa. Here there is a discrete ulcers as per the description given, and I suppose the surrounding mucosa is normal. So that will definitely favor Crohn's over other possibilities.
Thank
I
you.
think
So
I'll just make a small announcement. I think all of you who want to, of the audience who want to send in their questions, can actually type it in, and we will take it at the end of the session. Vishal, you can carry on,
okay.
please.
Yeah,
So
sorry,
I think,
Vishal, can I just add just one thing that we don't have any imaging for small bowel or we don't have upper GI because she had pain upper abdomen. So that was in my mind whether she has, upper GI
not
pain.
yet.
It's little odd to have
Yeah.
because she has left-sided disease. So that was
Yeah.
what
So
was coming to mind whether upper GI or CT was done or do we have imaging or not?
not at this stage, sir.
Okay.
So this is what we have at this stage. So So she was started on prednisolone, 40 milligrams once daily, mesalamine 2.4 grams per day, and azathioprine. So I'll go to Dr. Matthew Philip. Would you agree with the therapeutic approach which was taken here?
Thank you, Vishal, for this interesting case, and I agree with Dr. Ajit Sood, because the information given is inadequate, and with this mild disease of 2 to 3 stools and predominant upper GI symptoms, and not working only with the colonoscopy showing a left-sided disease, if I'm not sure whether it has gone into ileum, I need to have a very thorough checkup of this patient. I need to work up this patient properly, and I want to do a stool examination. I want to look for fecal calprotectin. I want to do a CT angiography, and because of upper GI symptoms, I may even do an upper GI endoscopy. I'll make sure the diagnosis is correct, and then I will actually plan the treatment. Because clinically, if you look at that, this patient has a very mild symptom, 2 to 3 stools per day. And in those situations, because the colonoscopy which showed extensive disease, though it is only one segment involved, but there's multiple ulcers there. So endoscopically, it appears to be a severe disease, but I need to know all
So
the
sometimes, yeah. So I agree with you that the symptoms are relatively mild, but at least on colonoscopy, it seems that there is some amount of aggressive disease.
I agree.
And we know that, I mean, the symptom and endoscopic things can be a mismatch in Crohn's
Yeah.
disease.
No, the only thing is that her symptoms basically upper abdominal pain. And, so I was wondering that we need to do more workup on this patient. I will definitely,
Absolutely.
I will not treat this patient without doing a CT angiography, and I need to do a MORS test, and we need to do other tests. And if I want to do start her on immunosuppression, I need to avoid other infections like tuberculosis, etc.
Professor Bhatt for, yeah.
Just a question. See, we have now got a patient who's got central abdominal pain, then upper abdominal pain, and we are seeing ulcerations only in the left colon. I mean, would it not be important that we also have, of course, I assume that you're saying the right colon and terminal ileum is normal. Should we have biopsies of that to help us sort of make a more definite diagnosis of IBD Crohn's?
Yeah,
Yes,
so
yes.
there was a focal. So I totally agree that possibly one would do more workup.
Yeah.
But I think somebody took a call that this is Crohn's disease and this treatment was started. Now let's for a moment assume that we all agree that this is Crohn's disease. So quick comment, Dr. Matthew Philip, that would you agree that this could be a good initial strategy to treat this patient?
See, here actually that's why I asked you. I need to stratify this patient for a risk stratification. And mesalamine, I may not start on this patient unless I am sure about the diagnosis. And here, if the disease is localized to left disease only, and if the patient, all other areas are normal, and concerning the mild symptoms, this could be okay. And because you are giving me a guarantee that it is Crohn's disease, the biopsy is actually not that fantastic. It surely shows acute ileitis and acute colitis. We want a diagnosis of, there is no evidence of chronicity in that, what is provided here. At least we should look for evidence of chronicity here. And this, if that is there, I think this is, considering the other symptoms, this could be an optional one, prednisolone followed by azothioprine. But now, having said that, there are a lot of studies saying that now, if you want to hit, if it is a Crohn's disease, prone Crohn's disease, you can actually choose how to choose your patient for a top-down or a step-up. And I agree that most of us, especially in India, we go for a step-up therapy, and we start with patients with prednisolone followed by azothioprine, and then only when they actually become a little more worse, then we actually go for a. But in this patient, there is no fistulizing disease. There is no evidence of any B3 disease, no evidence of any other high-risk factors. In those situations, probably you can go in for a step-up approach. But given the choice, discussing with the patient, if you can hit them early, and then I think this is also a possibility to give a top-down. You start with a advanced therapy earlier and come down with the other type of therapy. But here, with the opinion, with the options you have given to us, I think even a step-up therapy is a possibility, and I would probably go for that.
So I agree with the.
If we calculate HBI, HBI will not be more than 7, or if you take it as 3 stools or 3, and pain is there, one score for pain, I think HbA will just be 6 or 7. I mean, it's not really fitting into even moderately is again a borderline case.
Right.
And
So,
but yeah.
so I think I think we'll move forward here, and I agree that in some of the situations it may be reasonable to have a top-down approach where you start biologics relatively early or actually at the start. And although this concept has been there for from 2008, when the first trial appeared, which was actually at that time there was no concept of a maintenance infliximab. So this was just an induction infliximab compared to standard therapy, and even with that, the rates of remission were much higher. And now recently, a couple of years back, we had the profile trial where patients who had newly diagnosed active Crohn's disease were randomized to either a top-down approach, which combined infliximab with immunomodulators, or an accelerated step up. And you can see, and now you have actually long-term data published very recently in the Lancet Gastroenterology Hepatology, which shows that the steroid-free clinical remission and endoscopic remission were higher with the top-down approach. And so this could be a reasonable approach in some of the patients. And I think Dr. Matthew did hint at the kind of patients he would want to, start on a step-up approach versus a top-down approach. So certainly those you have an aggressive disease, fistulizing disease, you would want to start a top-down approach. But evidence is also now shifting that even in patients who may have an inflammatory phenotype, it may be okay to start a top-down approach. So in this respect, I'd request a quick comment from the panelists. I think Dr. Matthew wants to come in.
Yeah, no, I just want to say that, in all my patients now who has got moderate to severe disease, I straight away go for advanced therapy now. Because, at least I discuss with them. The concept has changed now. Only in mild disease, we actually go for that. Or only in inflammatory disease. That now, because of availability of small molecules, I think, now there is a justification of starting them on high quality or highly effective therapy initially itself, hit them very well, and then you can, because our practice itself, those who have started, we have started them on some sort of advanced therapy earlier enough. They're all doing very well. So I think there is justification to start on advanced therapy early enough, at least in moderate to severe disease, all moderate to severe disease, irrespective of whether they have got fistula or not.
So I would agree that availability of relatively cheap advanced therapies can possibly, shift our approach, which traditionally has been step up, largely because of issues of cost. Professor Sood, would you want to comment on that?
Yeah, I agree that the problem with us has been with the use of biologics was the cost. Now with the availability of generic forms of JAK inhibitors, I think the concept has to change as cost is no more an issue. And once we know that it's a patient is having moderate to severe disease, I'm saying please moderate to severe disease, I'll go for a top-down approach. If we look at it, if we go with the other therapies, if you still use 5-ASA, and if you use ASA and 5-ASA and azothioprine, the cost difference between JAK inhibitors, UPA, and the 5-ASA and azothioprine is really not substantial. So I think with the change, with the availability of generic forms of JAK inhibitors, the concept has to change.
So Dr. Bhatt and Dr. Padi, for any comments, any additional comments?
I agree that evidence favors early treatment, aggressive treatment, but the realities is what we'll have to look at. Patients may not accept, advanced therapies up front. They have a lot of apprehensions. But I agree with Matthew that if everything else is all right, your choice will be advanced therapy. I agree.
Moderate to severe disease. I mean, not mild disease. We have to segregate between mild to moderate.
So we are talking mild disease is basically those ones with little aphthous lesions here, there in the thing and hardly any symptoms. But this patient, symptoms are not much, but there's very significant colonic disease. So I think we need to sort of, we know the HBI is not all that great.
I think at the same time, I was just thinking that we also need to caution that there is a significant proportion of people which is in the range of mild to moderate. So there is this fine line between mild to moderate and moderate to severe. But for all cases, even for mild, I don't think we should uh, go ahead with these drugs. I think that is a word of caution. What do you
So
think?
to summarize whatever opinions have come across, that it would be now reasonable to consider starting upfront advanced therapy in moderate to severe Crohn's disease, other things falling in place. So these are some of the issues with this kind of an approach. I think we want to start advanced therapy because we believe that it will reduce hospitalization, surgery, probably reduce aggressive phenotypes or conversion to aggressive phenotypes, and reduce cancer risk, especially in colonic Crohn's. But the data on these outcomes is not really there. It is emerging. There are concerns about, and there have been concerns about costs. Probably that's less of a concern with generic JAK inhibitors now that we have. There is a concern about adverse effects of these drugs, including an increased risk of infection and feasibility over long term, which may be loss of response to that particular agent, immunogenicity when we are using biological agents, and issues related to compliance over a long period of time. So these are obviously some of the things to consider when we are suggesting a top-down approach to our patients. We move forward, and this is slightly later, maybe 6 months later. Patient had initial complete relief with steroids. However, with tapering of steroids, there was a return of symptoms, and she was given a second course of steroids. The azathioprine was hiked to 100 milligrams per day, and mesalamine was continued. And there was a discussion with the patient about possible use of advanced therapy. There was no insurance, and the patient was not affording the therapies at that time. So by January 24, the patient was in clinical remission in respect to the stool frequency, but she had significant anal pain, which was there with defecation, and she was found to have external hemorrhoids in examination. Now, sigmoidoscopy showed superficial and longitudinal ulcers at descending and sigmoid colon. CT enterography showed few asymmetric long segment thickening along distal, transverse colon, descending colon, sigmoid colon with increased vascularity. And in view of non-affordability, she was continued on the same therapy. So I will go to Professor Bhatt. I think the problem at that time was the cost of the advanced therapies. Would you consider any low-cost interventions at this stage, I mean, which might work in Crohn's disease?
The usual low-cost interventions that we have are basically 5-ASA, steroids, maybe budesonide, maybe something, especially if you have something in the left side. I don't know whether what preparation of budesonide will reach there. But low-dose steroids sometimes can be used. But obviously, there are problems of long-term use. But one of the things that patients already on azathioprine. What we could also consider is dietary interventions. Maybe a partial enteral nutrition with a Crohn's disease exclusion diet, I think is a low-cost intervention which may benefit, and we know that the results are pretty impressive.
I totally agree. I mean, of course, there's a lot of data on EN, which is slightly difficult to implement. But I think the concept of whole food dietary interventions is gaining ground. And there is now actually data of not just CDED with pen, but also CDED alone, even in adults. And I think people are also promoting what is known as tasty and healthy diet, which is being used in some of the preventive trials on Crohn's disease. So I absolutely agree that diet would be of benefit in some of these patients and would be a relatively low cost intervention in our patient.
Sure. Can I add one more? I mean, the other option we can consider is methotrexate, and especially people who are developing adverse events with azathioprine. Methotrexate can also be a good cost-effective alternative in suitable patients.
Yeah, I mean, obviously that will be as a substitute rather than an add-on therapy. I mean, I agree with
people who are not responding to our.
Okay.
But Vishal, one thing that this patient has got anal pain, very unusual for an external hemorrhoid, unless it's thrombosed.
Thrombosed, yes.
Either we're missing a small abscess or a fissure, maybe.
So obviously, I mean, there was,
can I
yes,
make a
sir,
slightly
Professor Sood.
controversial statement? The
Most
23
welcome, sir.
has availability of tofacitinib. And what we have found that tofacitinib also works in Crohn's, more so in the left colon. So if we see the cost of tofacitinib in a country generic form and the cost of 5-ASA and azathioprine, I think it's almost comparable. So we cannot recommend because literature does not support this, but the real world we have experience of using tofa in Crohn's, and I will admit that it does show response. I mean, we had nearly 40% patients who showed response, not remission, but response. So if there was no choice, I will definitely consider DOFA as an option. This is, we are talking in 2023. Of course, not today.
So I would agree that there is limited observational data which suggests that tofacitinib may work in a proportion of patients with colonic Crohn's disease. Of course, let us be clear that randomized trial data did not show evidence of benefit as far as tofacitinib is concerned. With that caveat, I think we move forward. So obviously, because this patient had some amount of inflammation and disease activity, there were intercurrent events which were happening. So she was admitted elsewhere for a diagnosis of viral pneumonia, and oseltamivir was given. And as Professor Bhatt pointed that there may be more to the perianal pain. She actually developed a perianal sinus, and she was suggested a MR, but did not follow up with the MR. And although she was not on, follow-up during this period, she continued to take azathioprine. So what we have is clinical remission. The stool frequency seems to be kind of settled, but there is endoscopic activity. There is activity on CT, and possibly we have some perianal disease, smoldering perianal disease. It is very important to define what are the targets to treat in our patients. So, Dr. Bhatt, how do we go about deciding the targets to treat?
Yeah, what we generally do is first we map out the symptoms. So we map out the symptoms. Now this patient has got pain. He's got some amount of bowel frequency. He's developed some problem in the perianal region that we need to address. And we've not spoken about fatigue, tiredness, ill health. We've not discussed that at all. But that's all that we need to factor in and say that that's our first target, is to make him feel better. So clinical response, and then you go further, after a few months at least, we try to target something more, including changes in his biomarkers, CRP and things like that. And then obviously give enough time for the bowel to respond and look at mucosal healing, transmural healing, and things that, which occur later in the game. So first define the problems.
And obviously, I mean, these are the targets which have been suggested in the STRIDE 2, and I think STRIDE 3 is going to come soon. And we believe that there will be some changes in the targets. But as of today, the deeper healing remains is a target you would want to achieve, but is not a clearly defined target. But what we have are immediate, intermediate, and long-term targets defined over a period of 3 months for immediate to around 1 year for long-term targets. And eventually what you want to achieve is an endoscopic healing. Targets may vary, and there are actually real-life determinants for targets. I mean, the cost, the risk of adverse events with the therapies, these are the factors you would want to consider. People may be averse to colonoscopy, especially when they're in clinical remission. And then obviously in elderly, you may be okay with just controlling the symptoms rather than really targeting deep remissions, etc. So there are a lot of real world determinants of targets to treat, and these need to be individualized from patient to patient. So apparently by August 25, now this is almost, quite a bit late into the disease course, the perianal sinus had apparently improved by itself. There was an upper abdominal pain which was ongoing, and patient also had periumbilical pain and loose stools. An upper GI was done, so esophagus and duodenum were normal, but aphthous-like ulcers were noted in the gastric body, And the histology showed focally enhanced gastritis and evidence of microgranuloma. So I'll now go to Dr. Kiran Peddy. How common is upper GI Crohn's? And when do you consider doing an upper GI in patients with Crohn's disease?
Thanks, Vishal. So, I mean, usually we see under 10% of these patients would have upper GI Crohn's, and more and so in younger patients, the two predictive factors are younger in onset and also male patients. These two are category. We need to have a high index of suspicion for anybody describing mild upper GI symptoms as well. So, if somebody is predominant, this lady has been describing an ongoing upper abdominal pain from the beginning. I think in such cases we should do endoscopy rather early than later. But if somebody without symptoms but male and younger in onset, we should seriously consider excluding it proactively.
Yeah, I agree. I mean, so in adults, as of now, the suggestion is to do a upper GI in individuals who are symptomatic. In pediatric population, usually it is done for every patient with Crohn's disease. I think Dr. Matthew Philip and Dr. Sood want to come in. Dr. Matthew Philip.
I actually do upper GI endoscopy as in index cases in all the patients, especially the younger. I definitely do, and it is not because of just symptoms. Means 100% here. That's why I told in this case you should have done an upper GI endoscopy. What I've noted is that irrespective of normal mucosa, sometimes you get antral granulomas and focal enhanced gastritis. And when there is a doubt about the lower systems, actually lower GI endoscopy actually shows inconclusive diagnosis. This will actually help me sometimes. If you see granulomas in the antral, so in a couple of cases actually helped me. And also when those are symptomatic, not in this case, those are symptomatic, but your evaluation of colonoscopy and all is negative, there is actually an indication for evaluating the small bowel. Even if the CT is negative, you can do a capsule endoscopy to look at that. If you clinically suspect somebody is having Crohn's disease and your evaluation negative, but the patient is symptomatic, I would even do a capsule endoscopy in those patients to look for ulcerations there.
So one capsule is 8 years tablets of upadacitinib.
I agree. But without diagnosis, how can you start upadacitinib? If you got a diagnosis, is fine. I'm talking not for this patient. I'm talking about when there is a doubt and you are not able to make a diagnosis and there is no other evidence in those cases. Okay.
So negative upper GI, negative colon.
Yeah.
And still considering Crohn's disease. Okay. I think we move forward and a colonoscopy was done at this stage. You can see evidence of active disease. And you can see that some of these are relatively small ulcers here, a bit of hyperemia. Then this is more of a longitudinal ulcer. And here, clearly you have a relatively, not very deep, but still a slightly deep ulcer. And then this is running longitudinally. So obviously the patient has upper GI involvement, has a lower GI involvement, active disease on endoscopy. I think all of us would agree that there is a need for an advanced therapy. But I would request Dr. Ajit Sood to guide us. How do we choose advanced therapy in these patients?
Thank you, Vishal. Now, I think in 2 years' time, the mucosal healing has not happened, and we don't really know about the transfusion disease status. So I think there's a clear-cut case for moving on to advanced therapy. Now, the question is that which advanced therapy? Now, we have biologics, we have small molecules, and I will say that luckily at the moment, we don't have a very complex algorithms to choose from. We have anti-TNF, we have anti-integrins, and we have UST among the anti-interleukins, and we have only JAK inhibitors. We don't have CYP1 receptor modulators at the moment. So we have lesser number of medicines available to us, and that keeps the job a little simpler. I think when we decide between the different drugs, I think what the parameters which help in making a decision is the severity of the disease, the site, the disease phenotype. Like somebody has got a perineural disease, obviously we have to go for drugs which act rapidly, extraintestinal manifestations, age of the patients, comorbid conditions, past exposure, and past exposure to biologics and anti-TNF agents, and the structuring disease or not. I mean, these are some of the things what we take into consideration. if disease burden is very high, if inflammatory burden is very high, we will go for a drug which act very fast. And in faster acting drugs, we have anti-TNF agents, specifically infliximab, and small molecules, I would say JAK inhibitors, UPA. So these are the two drugs which act fast, but we know that they are the ones which have a higher number of adverse events also. So if disease is severe, my decision will go towards this. If patient has a moderately severe disease, then we can consider vedolizumab as a good option. And UST is also a good competitor, but for moderate to severe disease. And so we decide about the disease phenotype, severity, presence of EIMs, past treatment. So these are the factors, and of course, patient preference. I mean, that is one of the important issues when we decide. And as we all say repeatedly, that the cost is the main thing. And when we escalate the therapy, it is not only the disease biology which decides; it's the affordability which also contributes decision making.
So that's an excellent summary of this very, very complex decision making. But I would just quickly focus on this living review, which is based upon a network meta-analysis. This divides agents into high efficacy and low efficacy in patients with advanced, who have not been exposed to any advanced therapy. And here you can see that certolizumab and upadacitinib apparently are low efficacy as compared to the other agents which are available. I have deliberately kept IL-23 antagonists also in this PowerPoint, because they are hopefully going to become available to our patients very soon. When we are talking about people who are already exposed to one or more advanced therapy, then there is some change in the relative efficacy. Upadacitinib apparently comes up, as do IL-23 blockers, and then vedolizumab seems to go down here, becomes less efficacious in people who are already exposed to advanced therapy. So this is based upon a network meta-analysis, not many head-to-head trials, and obviously the caveats to interpretation of this, but this has been used in the AGA guidelines, so that is why I mention it here. Obviously, as Professor Sood said, the intercurrent things, I mean, perianal disease, EIMs, whether patient is planning a pregnancy, family, or ongoing lactation. These are some of the things which you take into consideration, the age, any dermatological and ocular manifestations. So these are the points which you would consider while making choices about the advanced therapy. Dr. Sood, I'll also want you to comment upon the differential efficacy of different drugs depending upon the site of the disease.
Yes, I think that's an important issue. Now, if we look at the mechanism of action of various drugs, anti-TNF agents, small molecules, they're more systemically acting drugs, while Deolizumab, anti-integrin, this is more gut specific, and the gut specificity is more for the colon and the small bowel. So if we think of a disease which is having a widespread disease, or where we need a systemic action, I think anti-TNF agents and UPA are good drugs for Crohn's. But of late, what people have experienced, though data says that UPA works equally good in small bowel and colon. But most of the people, they have, I would say, feeling, or they found that UPA works better in colon compared to small bowel. So this is not well reported in literature, though all the registration trials did not show any differential action. But this is what, like, while talking to different people, everybody feels so. So, but the literature says that it's equally effective for small bowel and colon.
So I'll just, this is largely based upon a meta-analysis which looked at the trials and took patient-level data and looked at, the initial site of involvement and the efficacy. And if you see in general, except probably for anti-integrins where efficacy is equal both in colon and the ileum, in general, the drugs seem to work more in colonic disease, I mean the biologics. And for upadacitinib in the initial trials, it does not seem to be very, very efficacious for the small bowel disease. EEM is one intervention which seems to be more efficacious in the ileal disease as compared to the colonic disease. But broadly, most of these agents work in both of the colonic and the ileal disease. I would be slightly varied based upon the data to think about JAK inhibitors upfront in ileal disease. Of course, as Professor Sood did point out, that there are some observational studies which suggest that it could also work in ileal disease, but I think the final word is not yet out. So eventually, the decisions on advanced therapy take into account efficacy, concerns about safety, preference about mode of administration, clinicians' experience, the presence of EIMs, and most important in our thing, sabse bada rupaiya, the cost of the therapy. And in our patient, a decision was taken to start upadacitinib primarily because of the cost considerations in our patient. So I'll now go to Dr. Bhatt. We want to use this drug safely. So is there a checklist? If there is a checklist, what are the components that you would want to, preemptively assess before embarking on upadacitinib?
Like a lot of these advanced therapies, I mean, the concerns are of infections, most of the thing. And in specific for JAK inhibitors, we have the problem of thrombosis and cardiovascular events. I think those are the important things that come. Malignancy and all are also issues. So anyone who is older, who has evidence of cardiovascular disease or has previous evidence of thrombosis or pulmonary embolism, obviously you think several times before you want to consider this molecule. So I think history-wise, you sort out that. Then obviously look whether he's got latent tuberculosis, that like we do for our anti-TNFs as well. We look for other viral hepatitis, and of course, age, risk of malignancy, all that gets factored in. But I would say some things definitely some patients rule themselves out primarily because of their history. And of course, then you do the labs, which you have enumerated here on your slide.
Dr. Sood.
One quick, besides this, I think we should ask about history of smoking and obesity and sedentary lifestyle. And Dr. Bhatt mentioned about age. I think that's also true because TOFA we don't generally recommend beyond 60 and UPA we don't recommend beyond 70, 75. So people who are obese and sedentary life and smokers have a high risk of thromboembolic complications. So we should avoid JAK inhibitors in them.
So I'll now quickly, some of the important points. Yeah, sir.
But risk of cardiac disease itself has been often used, at least in trials, to sort of keep them away from JAK inhibitors. So I think we need to be, if there is another safer option, consider that.
So now we'll just address some of the important things which a clinician would want to know regarding using upadacitinib. And I'll go to Dr. Kiran. So Dr. Kiran, sometimes, in ulcerative colitis, you start steroids and upadacitinib or JAK inhibitors. Is there a role of, starting them together in Crohn's disease?
Yeah, so mechanistically, basically, the upadacitinib has got quick onset of action. And one should be, if the patient is not severely symptomatic, I personally would start only single agent upadacitinib for the fear of opportunistic infections. Because 1 + 1 is not going to be 2, it is multifold infection risk. So patients are starting on steroids along with upadacitinib. But literature supports using dual therapy, but most of this literature is from Western countries. I think from Indian setup, I would rather vary using both together because at the end of the day, the onset of upadacitinib is quick in onset. Patient usually gets some kind of symptomatic response in a week or two. So it should be okay to start monotherapy in my opinion.
So I would agree with Dr. Kiran. And this is, again, not directly answering this question, but this is data from the initial trials of upadacitinib where you have comparisons between patients who were put on steroids, who were using steroids at the baseline or were not using steroids at the baseline. And you can see that the difference from placebo is not really very different. So it is okay to kind of consider starting upadacitinib alone in patients with moderate to severe Crohn's disease.
But Vishal, if the patient is already on steroids and you're contemplating starting on upadacitinib, would you stop Steroids or you continue?
These trials had a mandatory taper of steroids, so which means that you should start
Taper
tapering
them
the
quickly.
steroids when you start here.
Correct.
Now I go to Professor Sood. We are always interested in the response. So how quick is upadacitinib as far as the response to the symptoms of patient is concerned?
Yeah, I think this is one of the rapidly acting drugs, most rather fastest acting drugs. And the symptomatic response starts coming within a few days. But by 2 weeks, I think most of the patient, the response becomes evident. And but we have to keep it in mind that the induction therapy for Crohn's is up to 12 weeks. Even if there is a slight delayed response, it doesn't mean that we make a decision of changing the therapy. But the response, by and large, I would say majority of the patients who are responders they show response by week 2, and it is shown that the faster the response, the better the outcome in the long run.
So you can clearly see that here, as far as pain and stool frequency is concerned, almost within the by the end of first week, you start seeing a clinically significant difference. And while in ulcerative colitis, it is within days, here it is at least, by the end of the first week, you start seeing some difference. I'll now go to Dr. Matthew Philip. So, sir, in some of the patient, this was mentioned, that people may not have an initial response. So, how long would you want to kind of continue the induction phase, and what is the strategy in patients who may not have an initial response?
See, of course, in JAK inhibitors, as a significant group may not have initial response. When you look at that, it depends upon the site of the involvement and other factors of these patients. But generally, our experience is actually evolving. But what I've noticed is that, I wait for some time, because if there is some response, I wait, and I will actually make any changes only after the induction period. And most of the time, the induction period now, many times I shift from 8 weeks to 12 weeks. And after 12 weeks only, I really decide to change. But, if the patient is worsening, then I will actually change the drug. Otherwise, from it really take sometimes up to 12 weeks to see the clinical response and the lab parameters response. The response may be slow, and does not mean that you should immediately stop that. So I believe that you will get some response initially, and if there is some response, I will try to continue the medications for at least 12 weeks and see the response before I stop the medications.
So that's an important point. I mean, this is again data from the initial trials, and amongst a subset who were given upadacitinib 45 milligrams, 194 patients did not have a clinical response at 12 weeks, and they were continued on 30 milligram of upadacitinib for another 12 additional weeks. And you can see that half of them actually had a delayed response. So delayed clinical response to upadacitinib can occur actually in a substantial number of initial non-responders to this therapy. Dr. Bhatt, we have two maintenance doses which are available, 15 milligram and 30 milligram. So what should we be using?
Yeah, our policy is to come down to 30 in most of our patients. I'm not even sure whether 50 is available in India, but correct me if I'm wrong. But we use 30. And certainly those who have had a slow response would definitely go on 30. I think the big advantage of 15 milligram would be those who you want to bring down because of adverse effects or things like that. You want to bring down the dose, then you have an option of 15. Otherwise, by and large, I think it'll be 45 and step down to 30 in most patients.
So 15 is available, but I agree that, and even in this trial, you can clearly see that there is a numerical difference on maintenance data, in the maintenance data, when you compare the 15 milligram versus 30 milligram maintenance. And I think it is appropriate to continue 30 milligram maintenance. So there are some variations in clinical practice which have been reported in the literature. I'll quickly go over these. That in patients who have refractory disease, multi-drug exposed and refractory disease, it may be reasonable to continue a high dose of maintenance. In individuals who relapse after you go to 30, or there is a loss of response on 30, you can actually re-induce with 45 milligram and continue high dose maintenance. Upadacitinib has also been used in advanced combination therapies. And actually, there is a randomized trial with vedolizumab, which was presented at ECHO this year. But there are also studies with ustekinumab, sometimes even with TNF inhibitors, although I will be very wary of combining these two, and of course with IL-23 antagonists. And there are anecdotal reports which show benefit in upper GI Crohn's disease. So this is the overall summary of the literature that we have. And in our patient, the symptoms actually improved. There was Dr. Bhatt, sorry.
Yes, Vishal, just like we use a TOFA, I mean, we keep increasing the dose at times or stretching the things. I think the same rules kind of apply in the Upada as well. So I think we can be a little more flexible on the dosing without getting restricted like we do for the other biologics.
Agree with that. So symptoms were better. There was a gain of weight, but the patient developed. So this patient was not vaccinated initially for herpes zoster. I think at that stage, patient felt that it was very costly and the vaccination was not given. So she developed a vesicular painful rash, which was dermatomal in distribution in the right arm and chest. The Zank smear was positive from this, and she was started on oral therapy, oral valacyclovir 1 gram TDS for this. So I will now go to Dr. Kiran. How common is like zoster with JAK inhibitors? Once zoster happens, would you continue JAK inhibitor? Would you consider vaccinating this patient after initial episode of zoster? So how do we go about this?
The relative risk with JAK inhibitors is about 3 to 4 compared to placebo with incidence of shingles. And I certainly would always vaccinate these patients with shingles and with Shingrix, because now it's a recombinant vaccine available for us. So it's always better to vaccinate them before starting, or even after starting the JAK inhibitor, we can safely vaccinate these patients. And what was the second question?
So the second question was that, should we...
So once you continue, so if the patient has developed uncomplicated shingles, then there is an argument to continue the same dose of JAK inhibitors, but certainly not with a complicated zoster. And patients again with disseminated zoster and all, one can think about stopping completely, giving a break, and then restarting again at some point.
Every 2 weeks, one can hold it. And I will share our experience that we have seen that around 3% people do get shingles, but so far so good. I mean, none of the patients had a systemic disease, and all of them have a single dermatome shingles, and they responded. And we've been able to restart in all patients.
So similar experience. In fact, in some of the patients, we have been able to continue the JAK inhibitors even while there was a zoster, and we treated for zoster. So this is again one study where you can see
a role for vaccinating them even after zoster, right?
Absolutely agree. So you can consider vaccinating even after the initial episode of zoster. In fact, if somebody you have vaccinated, I mean, sometimes, you start the vaccination and the drug almost concurrently. Yes. You have to. And let's say somebody develops zoster, you still go on and give the second dose as scheduled. Correct. So these are important things when considering the vaccination. Dr. Matthew Philip wants to say something.
No, I just want to ask you that suppose a person develops zoster, and when you should vaccinate? I believe that for 1 year it's not necessary, so you can vaccinate after 1 year, because otherwise I'm not sure about the recommendations on that.
Suppose there are two recommendations, sir. One I think I can't remember. I think it's US guidelines say that once acute episode subsides, you can vaccinate these people. But the Canadian guidelines, if I remember correctly, they would advise to wait for 1 year before vaccinating after zoster.
So I think this is one important study which looked at people who were actually discontinued on JAK inhibitors after initial episode of zoster versus those who continued. You see that the risk of zoster is kind of similar in both the groups, which means that even individuals who had zoster have the same risk as those who have not had zoster. And so it would be reasonable to vaccinate. And while you would probably want to vaccinate before you can start the drug, because the responses are much better when the patient is not on JAK inhibitor, but sometimes it is not feasible and it is still okay with, of course, slightly reduced efficacy to vaccinate individuals even while they are on JAK inhibitors. So this was the colonoscopy at 4 months after upadacitinib, and this is remarkable. There's absolute healing in this particular patient, and we are continuing on maintenance dose of upadacitinib. So just a last comment about upadacitinib in specific situations. I think I'll not go to the panelists for this. For perianal fistula, there is very limited data. There is actually post-hoc data from the initial trials, and it seems that there is some improvement in fistula healing, which happens with upadacitinib. For post-operative prevention of Crohn's disease, there is no data, but in the trials, patients with multiple previous surgeries have been included, and upadacitinib was efficacious in those patients. For stitching Crohn's disease, there is absolutely no data at this point really say this way or that way. So to summarize, we have a JAK1 inhibitor in the form of upadacitinib generic, which is now available. For our patients, it has demonstrated efficacy in Crohn's disease, especially in colonic Crohn's disease. It has got a relatively quick onset of action. It is very, very important that a pre-therapy checklist is ensured and the assessment of various thrombotic and cardiovascular risks are assessed. Upfront vaccination for zoster should be considered, and we should avoid this drug in pregnancy, lactation, elderly, active venous thrombosis, and patients with active cardiac risks. I think I'll stop here. Thank the panelists for their very active participation, and see if there are any questions that we have from the audience to address. Thank you.
So we have some questions actually. Shall we take it now or at the end of the session? So I think these are all very generic questions. Okay. So the important question that has come is that in India, should we therefore not use biologics as first line and just use upadacitinib? Is one question from Ms. Dr. Palash Samantha, and similar line questions 3-4 others. So I think this is a difficult question. I thought that we could.
But Jackies are called as poor man's biologics. So, I mean, Jackies are called as poor man's biologics. So, I think if, as I mentioned, that's the disease biology and in addition, the affordability which matters. So, I will not mind if patient doesn't afford, like this lady, if she couldn't afford other drugs and she responded so well to JAK inhibitors, I think there's no harm in advancing therapies. I mean, now the FDA also says that it's not stringent that you have to use biologics and then use UPA. So, I think we learn with time and we have now good experience of using Jackies. We feel that we should have more prompt use rather than being restricted to only anti-TNF exposed or biologics exposed. Those who can't, we should.
Also said earlier, as you said earlier, I think the word of caution that we still have not broken that 40% ceiling. Only a limited number of patients do respond. So keep the other options open. Yes, you may be pushed to a corner and use this as first-line therapy. But believe me, over a period of time, we learn that we may have to go back to the other biologics to bail us out. So in my practice, I still do not use Upada as first line unless, I mean, we are pushed to the corner and the patient can't afford anything else. So we still use the other regular.
I agree with both Professor Sood and Professor Bhatt. For us, somehow, the kind of patients that we deal with, Upada becomes the de facto choice, first choice. Largely related to the cost considerations. But I agree that we tend to give all the options. We tend to suggest that given your profile, age, the comorbidities, the EIMs, the risk factors, this is the best therapy maybe. But then eventually cost, I think, drives sometimes the choice of therapy.
Vishal?
I feel that it may be worthwhile because we have some youngsters who prefer once in 2 months single shot of ustekinumab rather than have regular things. So it is important to discuss the various aspects, and if cost is the factor, then of course upadacitinib alone. Dr. Matthew Philip, we'll just take that comment and then go to the next case.
I just want to say that, actually, one thing, Jackie has made our life much easier. Now, our inhibition of starting an advanced therapy has gone. Now we have got choices where we can actually start an advanced therapy much earlier. So I think, that is very good. Another thing is that, I just want to ask Dr. Ajit, you have been using TOFA for Crohn's disease on left-sided colitis, left-sided disease. In the presence of UPA, will you still continue that, or you will switch over to UPA?
No, we are switching over to UPA.
Yeah. Okay.
And I will just one comment that the IBD is becoming more severe phenotype now in India.
No, actually, we are seeing much severe earlier enough. And IBD, especially Crohn's disease, very, very different types of Crohn's. We have seen acute presentation with first time presenting with stricture intestinal obstruction, perforation. They do not have any major symptoms at all. So all this, even malignancy I have seen the first presentation. All this can happen.
So thank you, Dr. Vishal. Thank you, panelists. We have some more questions. Vishal, if you are around, then we can have it at the end of the session. We quickly go on to the next case. And you can see here that this is a case of ulcerative colitis now. There is a lot of data, and presenting this case is Dr. Anurag Jaina, a young, upcoming bright star in the field of IBD. Over to you, Anurag, to introduce the panelists and start the next session.
Thank you, Rupa ma'am and Dr. Reddy sir. I think my topic today is navigating the maze of ulcerative colitis. I have a very respected faculty group here. Dr. Ajay Kumar, who is the chairman and the head of BLK Max Delhi and the present president of CCF India. Dr. Usha Datta, the professor and head at PGI Chandigarh. Dr. Arshdeep Singh, consultant and at DMC Ludhiana. And Dr. Partha Pal, who is the interventional IBD expert and at AIG Hyderabad. So moving forward to the case, a 42-year-old female, a homemaker, ulcerative colitis, E2 disease, previous comorbidity of Graves, medication history of steroids and 5-ASA, and disease duration of 1.5 years. She presented to us with bloody mixed stool, 5 to 6 episodes per day, and intermittent fever for 7 days. Now, the bloody diarrhea was initially 4 to 5 times per day. It gradually progressed to 7 per day with nocturnal episodes of 1 to 2 per night. And there was blood in all the episodes. It was associated urgency, tenesmus, and mild lower abdominal discomfort. There was history of fever. It was intermittent, low grade, and there was history of burning micturition with urgency. On the past history, she was on 5-ASA and she had received 1 course of steroids earlier. There was history of complementary alternative medications for 1 month. There was no history of COX. She was a known case of Graves' disease on treatment. She was mother of 1 child and her previous menstrual history was normal. On examination, she was conscious. She had tachycardia. The BP was 112 systolic by 74 diastolic. There was bilateral pedal pitting edema. She had bilateral eye proptosis, which was consistent with the history of Graves' disease. Her abdomen was soft, but the bowel sounds were also present. Now, the initial sigmoidoscopy, there was rectum filled with maroon blood. There was complete loss of vascular pattern, friable mucosa, and areas of denudated epithelium. The UCIS reported at that time was 8 by 8. Now, this image provided is a representative image. The actual image was missing from the case file. So this had shown deep ulcers. The UCIS was 8 by 8. On the initial investigations, she had anemia. Hemoglobin was 5.8. The ESR was 70. CRP was 58. The calprotectin was 745. The stool for C. difficile was negative. Biomarkers was negative. The urine routine had 6 to 8 pus cells. The urine culture was also sent. On the initial biologic workups, the MON2 was negative and CCT chest was also normal. Now, my first question is to Dr. Ajay Kumar. Is Clostridium C. difficile a major problem in India?
Well, I hope you can hear me.
Yes, sir.
And thanks, Rupa, for this organizing a wonderful webinar, and Anurag, wonderful case. My comments on that is that C. difficile, I mean, till now we all believe that, at least in the clinical setting that we're talking about, that it is not a major problem with us. And the data which is published from the 3 different trials from India also shows that it is not a major issue. And but if you were to look at the other way around, in day-to-day practice, I'm not talking about the setting of UC specifically, that now we are seeing more C. diff what we use as compared to what we used to see, say, a few years back. And the reason attributed is number of reasons. The type of testing that we're doing, maybe the better test kits are available and so on. But whatever the data is, that C. diff is not a major problem in the setting of UC in India. And our experience is in totally agreeing with what the published literature is.
I think rightly said, sir. I think these are the 3 studies published previously from India. I think the first one was from AIMS. Out of 153 patients, only 1 was found positive, and the outcome was determined by the disease severity. The second paper is from Dr. Anupam at PGI, where he looked into a cohort of positive patients with C. difficile and compared those with a negative cohort. I think both the immediate and the short-term outcomes were determined by the severity of the UC flare. And the third study is a recent study from Dr. A.S. Puri. The prevalence was only 2.9%, and it was not a major causative factor for flares in moderate to severe ulcerative colitis.
Dr. Anurag, may I just add on to something, that there is some variation from within India also. In fact, our experience has been contrary. We have even reported a prevalence rate of up to 13% of C. diff in acute severe UC cohort. So it's I think the message should not go that we need not check for C. diff. C. diff is definitely a concern, and it should always be tested in a patient who presents with acute severe UC.
Yes, I think in every flare, I think we should test, but the outcome of the disease profile is more determined by the ulcerative colitis itself.
Yeah,
but yes, definitely when positive, it has to be treated. Professor Usha.
Jana, I just wanted to add here that when I was in Canada and I used to see patients with IBD there, definitely C. diff was an important component there, and which I don't find to the same extent in terms of severity as well as prevalence of the condition. So definitely Indians, maybe the diet or maybe the basic flora which we have may be different compared to what we see in the Western population.
Yes, so moving on, what are the initial steps of management of acute severe ulcerative colitis? Dr. Partha.
So I think this patient is having acute severe ulcerative colitis. So here what happens is it's a medical emergency and there is a cytokine storm going on inside. So I think, and also the patient is losing a lot of fluid and he's anemic as well. So we need to first stabilize this patient. He's tachycardic as well. So first, I think we need to check his, improve his electrolytes and also the fluid status. Then should start IV steroids in this patient, either hydrocortisone or methylprednisolone. And then I think there is good role for enteral nutrition in this patients. Actually, exclusive enteral nutrition has been shown to improve the steroid responsiveness as shown in the trial done in the AIMS. And I think also thromboprophylaxis is very important because in this systemic inflammation, there is hypercoagulability and chances of venous thrombosis, and because also more so because the patients are immobilized. So these are the initial steps for management of acute severe ulcerative colitis.
I think that was very well summarized. I think for fluids, we know it is calculated as per the requirement. That we don't have one fluid superior over the another as of now. The electrolytes, we have to look into hypokalemia and hypomagnesemia. We have to supplement the 60 milliequivalent per day for stool, and we have to calculate for the steroid-related loss. And we have to keep the target potassium more than 4. for medications, I think IV steroids are still the drug of choice. The anticoagulants and antibiotics, I'll come to it. Nutrition, rightly said, exclusive enteral nutrition has some evidence. The message is the patient should not be kept nil per orally except when you're suspecting perforation or megacolon. There is no role of oral 5-ASA in the present episode of acute severe ulcerative colitis. And there is no role of antidiarrheal agents, which may actually precipitate the megacolon. So coming to the steroids, I think what should be the first line of treatment, Dr. Arshdeep?
Yeah, I'll just add one more point. Considering the image of the sigmoidoscopy that we showed, it showed deep ulcers, and few of the ulcers were looking like punched out ulcers. So in addition to what Dr. Partha has just explained, I'll probably also start antivirals empirically, because waiting for biopsy will take at least 4 to 5 days, and we don't want to lose out on those important days. So if we get an endoscopic picture like that, we suspect CMV infection and CMV disease. So probably we can add antivirals if the disease is likely to be severe.
Only on 5-ASA for a long time. There's not much risk factor for CMV, although this attack seems to be quite endoscopically severe. So
yes, it's a severe disease, so it is a association with the severe disease. And yes, ma'am.
Yeah, go ahead. I'll talk after you do.
Yeah, and regarding this choice of the first line therapy, whether we go with IV steroids alone or combine it with JAK inhibitors, the guidelines still recommend use of IV hydrocortisone or IV methylprednisolone, that is IV steroids alone. But what the practice at our center is that after the publishing the report of the TACOS trial, actually our practice has changed, and we are now using upfront combination of corticosteroids and tofacitinib for patients with acute severe UC. And we'll be coming up with the long-term follow-up of those patients also in the next couple of months. And this strategy appears to be superior to the use of IV corticosteroids alone. And there are actually multiple trials now ongoing which are evaluating this combination or even JAK inhibitors alone. So there is a SMART trial which is registered from Dr. Peter Higgins' group, and Professor Shaji Sebastian in UK is doing a combination of steroids and upadacitinib. So no doubt the guidelines currently recommend IV steroids alone, but the future looks like it should be a combination.
Dr. Usha.
Yeah, so in patients when they have acute severe UC, we keep doing sigmoidoscopy and send a biopsy. The usual turnaround time for biopsies is 7 to 10 days in institutions like ours. So here I often recommend that to my residents that they write a special note to the faculty, and at which time within 24 hours to 48 hours you can get a histology report, especially in patients like these where we are suspecting CMV, also looking at the sigmoidoscopic appearance. I think it's very important to involve your pathologist so that you get an early report in these patients rather than the standard reports.
I think also ganciclovir itself can cause sometimes leukopenia and myelosuppression.
Yes, we have to watch for cytopenias, but
we are very fortunate that our pathologists give us the report within 24 hours. So we don't have to start the empirical ganciclovir for that reason.
So right, I think the message should be that IV steroids are still the gold standard and the first line of treatment. Combining with JAK, I think still we need more multi-center evidence, and I think the trials that Dr. Arshdeep mentioned, I think they will definitely throw light whether combining them with upadacitinib is going to be the game changer or not. But right now, the treatment of choice is obviously steroids. Now, this is that TACOS trial by Dr. Sood's group, where they have combined tofacitinib with IV steroids, and they looked into the clinical response with at day 7 as compared with placebo and IV steroids alone, and the clinical response at day 7 was comparatively higher in tofacitinib group, and the rescue therapy requirement by day 90 was also lower in the tofacitinib group. Now, if I have to ask Dr. Arshdeep, between hydrocort and methylprednisolone, which is the preferred steroid that you use at your center?
Yeah, we use hydrocortisone, but literature says both are equal in efficacy. So it could be either methylprednisolone or hydrocortisone.
Anurag, can I ask one question from the panelists? In a setting like that, especially Harsh, you are using quite a lot of this. Do you postpone your vaccination or do you give the first dose at the start? I mean, what is the policy there?
So for acute severe UC, we are not waiting for vaccination, but otherwise we are recommending vaccine to all.
You are not, obviously you can't wait here. What I'm trying to ask is, will you vaccinate them later after?
Yes, sir. Yes, sir.
Policy.
Yes, sir. Yes, sir. We'll vaccinate.
Any role of upfront surgery? I know we are, as gastroenterologists, we are not very keen on sending the surgeons on a day one, but is there any role of upfront surgery in acute severe ulcerative colitis? Professor Usha.
I think there is a lot of resistance from patients for upfront surgery. Secondly, it's a major decision. And I think first there should be a trial of medical therapy. There are only certain specific indications where upfront surgery is required when there is massive unrelenting hemorrhage, as you have mentioned. And this patient already has a hemoglobin of 5. I think it's important to transfuse so that you improve the mucosal perfusion and get the hemoglobin above 8 to 10 grams per deciliter. And if the patient has significant hemorrhage despite that, that is one set, and that is actually not very common. Second is if the colon starts dilating. So we usually have a daily X-ray policy and also have a daily ulcerative colitis chart. So if the stool frequency goes down or the colon starts dilating, then we start suspecting toxic megacolon, and those with impending perforation are the ones who will go in for surgery. And third is something which we see during screening periods where we see coexisting colorectal neoplasia or dysplasia. So that is not what we see in an acute severe setting. So in acute severe setting, I think patient who's not responding, patient is going into toxic megacolon and has any sign of abdominal tenderness and increasing TLC, those are the set of patients I would be bringing my surgeons in to discuss.
Agreed. I think the surgeon should be involved from the day one of management, provided we look into those complications. If any of these complications like hemorrhage or perforation develop, I think that is the time when surgeon has to be brought into the management picture. Now, do you routinely give anticoagulation in all patients of acute severe ulcerative colitis? Dr. Ajay Kumar sir.
Yes, my answer is yes. We do give because the policy and the guidelines and the literature data, it all says that any patient of UC severe enough to require hospitalization should be anticoagulated because it cuts down the risk of, because this is the population where the risk of thromboembolic complications is high, and it does help in preventing those complications and the morbidity and of course in some mortality. So our policy is to anticoagulate them.
I think this is the AG Expert Review 2026. I think hospitalized adult patients with IBD should receive prophylactic anticoagulation for prevention of venous thromboembolism. The hospitalized patients were 2 times more likely to have venous thromboembolism as patients without inflammatory bowel disease. The exact mechanism of thromboembolism is still unclear. Inflammation and steroid use contribute to the hypercoagulable state. And the prophylactic anticoagulation was found to be effective in reducing VTE despite increasing the risk of major bleeding. The number needed to treat was 35 compared with the number needed to harm of 114. We don't have any strong evidence whether anticoagulation actually gives benefit from Indian setup at least, but all the guidelines do recommend anticoagulation to prevent those life-threatening venous thrombosis which can endanger the patient's life.
So here I think Anurag, I would have a difference of opinion. I find that patients of acute severe ulcerative colitis who are admitted to the hospital, who are responding to therapy, who are walking around or can visit the washroom, they are the people who are less likely to have any thromboembolic complications of a major nature. And if you see that the number needed to treat is 35, that means out of, if you treat 35 people, one person is going to benefit. So we are adding to the cost of therapy where I don't think we really need it in all these patients. And you see hospitalized patients are 2 times at increased risk. So definitely acute severe ulcerative colitis, patient is bedridden, cannot visit the washroom, is not mobile at all. These are patients who, and those who are not responding to therapy, they are the ones who are at increased risk. So I would use anticoagulation in that subset of patients.
Any difference of opinion, Dr. Arshdeep?
No, I think that acute severe UC is a pro-inflammatory state, and we are using corticosteroids, which further increase this inflammatory and the prothrombotic risk. So, as a policy, we are currently giving anticoagulation to all. But I agree that in a very, very small subset of patients who are ambulatory, I say so because the SMART trial, which I talked about earlier, which is evaluating upadacitinib, they have a arm where they are going to treat on an outpatient basis. So maybe that group of patients we can probably avoid, but till the time we have evidence, I think it should be recommended for all.
So, role of antibiotics in acute severe ulcerative colitis, Dr. Parth.
Just let me add. So
yes,
what Arshdeep said is that you're treating as outpatient. It means those patients are fit to be treated as outpatient, and that's the reason.
Yes, sir.
The guidelines
Yes.
mention the patients requiring hospitalization.
Agreed, sir. Agreed, sir.
They use that word, then they say. No.
Agreed, sir. Agreed.
I think you are using now JAK inhibitors as well, which also increases the risk of.
Yeah.
Yes.
So definitely I agree with you that patients who are on JAK inhibitors hospitalized, they definitely need it. There the number needed to treat will actually come down. But in patients who are admitted, who are walking around, who are on IV steroids, they are the ones whom maybe for the first few days we can give and get it off once they start showing response. Because I find that routinely all these patients are continued on anticoagulation throughout their hospital stay, which may not be necessary. I know the guidelines recommend, but I think we have to apply it to our settings.
I think the answer to this would be identifying that subset of patients which you can sufficiently manage them on an oral omnacotril rather than giving a hydrocot. I think there has been a recent ECHO abstract which have shown that there is a subset of patients they tried to manage on oral prednisolone and the outcomes were good. So we need to characterize that subset of patients so that we will know that these are ambulatory patients and they might not require hospitalization. Now, any role of antibiotics? We know this patient has suffering from UTI. So, Dr. Partha.
So I think if there is any confirmed infection or suspicion of perforation or there is toxic megacolon, these are the scenarios where antibiotics may be necessary. Otherwise, I think in this randomized control trial also it was shown that adjuvant use of antibiotic did not improve either the colectomy rates or the response rates to the your steroids. So I think there is no role as such unless there is proven infection or complications.
Right. Now, this patient had the urinary tract infection. The patient was having fever spikes. The urine culture came out to be positive for Klebsiella pneumoniae E. coli. It was sensitive to colistin only. Patient was started on colistin with meropenem. Now, fever persisted despite 48 hours of upgraded antibiotics, and there was AKI. The baseline AKI, the creatinine went up from 0.54 to 1.65. So antibiotics were changed later to ceftazidime, avibactam, and the fever responded. Now, role of IV albumin in patients with acute severe ulcerative colitis. This patient had albumin of it had low albumin with hypoalbuminemia. So, is there any role of IV albumin, Dr. Arshdeep?
Yeah, hypoalbuminemia is a poor prognostic sign for acute severe UC. It is a part of all the prognostic indices that we use. And even if we think of a patient non-responding to corticosteroids and we are planning to give infliximab, still because of the increased drug loss, the efficacy of infliximab will go down. So it has been proposed that albumin may be effective for both increasing the response to corticosteroids also as well as infliximab also. There is actually very limited data that has looked into this in a systematic way. This is one trial from Professor Vineet's group. They combined albumin with EEN for acute severe UC to look at the response of steroids, and it was found that adding IV infusion of albumin once a day did not result in a significant improvement in the response to corticosteroids. But that said and done, if the albumin levels are very low, say it is to the tune of 1.5 to 2, giving IV albumin for 3 to 5 days may not actually do much harm, rather improve serum albumin, as was also shown in this randomized trial.
So, right, the role of nutrition in management of acute severe ulcerative colitis. I think the IV albumin, I think the long-term benefits we still don't know. So, what we have is the oral and the enteral nutrition. Dr. Usha.
Yeah, so what we routinely do is we keep the patient on enteral nutrition. If the patient can, in very severe cases, we go to exclusive enteral nutrition. Otherwise, we ask them to take simple home cooked, easily digestible food. We tend to avoid milk because many patients have lactose intolerance in our country, and lactose increases the diarrheal frequency. So simple diet, which is either exclusive enteral nutrition on one end, or on the other side, we could have a simple diet with dahi, khichdi kind of a thing, which is easily digestible when they are in the hospital. So this is what usually patients take. The other, as far as exclusive enteral nutrition, this is a study from the AIMS group which showed that addition of exclusive enteral nutrition helped in better remission rates, and definitely that is the way to go. So it can be delivered either through a nasogastric tube or orally. Most patients don't like nasogastric feeding. So if the bowel is moving, there is no tenderness, potassium is okay, and there's no distension, these patients can be started on exclusive enteral nutrition at the beginning, and there is no need to completely stop all forms of enteral nutrition in these patients, as was the practice earlier on, nil by mouth. So we slowly start depending on the patient's tolerance, and if the patient can tolerate, we slowly step it up. So that will be the way to go. If there is any tenderness, if there is any distension, then we try and review what the patient has been taking and accordingly tailor it.
I think in our patient, we started on her on IV antibiotics. We gave her heparin, Solumedrol 60 milligram was given, and 2 blood transfusion. On day 3, the stool frequency was still 7 per day, and there was blood in all. So, Dr. Partha, how do you monitor patients on steroids for response?
I think there are several criteria, but most commonly used criteria is the Oxford criteria, in which you see the stool frequency, whether it has decreased to less than 3, or it is between 3 to 8, or if it is still more than 8 even after day 3 of steroids, and also the CRP, inflammatory markers like CRP, and the AIMS criteria also includes day 3 fecal calprotectin. So these are the markers, and also I think there is increasing abdominal X-ray, daily abdominal X-ray, or alternate days based on the patient's symptoms is very important. And there is increasing role of intestinal ultrasound, because, say, for example, it's a point of care modality at day 2 or day 3, 48 to 72 hours, when you are just doing the CRP as well as or the fecal calprotectin at that point of time, or calculating the Oxford criteria, you can just also do the intestinal ultrasound. The bowel wall thickness in the most affected area, like the sigmoid, which is usually the case, that decreases by more than 20%. It has shown to predict the risk of rescue therapy and as well as colectomy. And also now there are more studies with transperineal ultrasound as well, which are being registered, whether they can predict the outcomes in acute severe ulcerative colitis, because they can directly see the rectum.
Yes, so there is a need of daily monitoring of clinical symptoms as well as the inflammatory markers. So so monitoring chart for acute severe ulcerative colitis is a must. And as Dr. Partha said, intestinal ultrasound has been a good modality to predict response to IV steroids as well in hospitalized patients of ulcerative colitis. This study, they found that at 48 hours, the responders had reduced bowel wall thickness. There was increased absolute reduction as well as relative reduction. And they suggested that a 20% reduction in the wall thickness had the highest odds ratio for predicting response to the IV steroids. Now, there are multiple scores. I think to look for the response to steroids, Dr. Arshdeep, which is the score that you most commonly use at your center?
Yeah, I think Dr. Partha has touched upon this. Oxford criteria still remains the most commonly used criteria to ascertain the response to corticosteroids. AIMS index has also been validated. It's derived from the Indian population. There is a small caveat with the Oxford criteria and the ADMIT-ASC scores. The ADMIT-ASC score I like to mention is usually calculated on the day of admission, because it predicts the response to corticosteroids. The caveat that is that what we have observed is that in Indian patients, CRP doesn't rise to the level as it is seen in the Western populations. So the reason probably is the polymorphisms in the interleukin-6 pathway, which is responsible for production of CRP. So these criteria usually tend to perform slightly under par if we compare to the Western populations. But nevertheless, in the absence of other criteria, we still rely on Oxford criteria to ascertain the response to corticosteroids.
So coming back to our case, I think the patient did not have response to steroids, and luckily the biopsy came that histopathology was suggestive of inclusion bodies. There was high tissue CMV. Blood CMV PCR was also more than 10,000 copies per ml. So now this case was basically an acute severe ulcerative colitis which did not respond to steroids, and with the diagnosis of CMV in this setup. So, a question to all my panelists. So, what do you do for the steroids now, and what is the drug of choice that you start in cases with CMV colitis in ASUs? Dr. Partha, if you can take it.
I think in acute severe ulcerative colitis, I usually continue the steroids, and I do continue the steroids. And how do we start? I usually IV ganciclovir, and based on the response, if the patient responds, then we switch to the oral valganciclovir over the period of time. And what are the parameters to monitor on ganciclovir? Because a few of my patients have developed leukopenia, so I monitor the blood counts as well as the electrolytes. So yeah.
So I agree with Partha. That's a standard way to manage. You give IV ganciclovir and after that shift to oral ganciclovir and assess usually the response to therapy clinically in terms of clinical response and stool frequency, as well as we can always do a tissue again if required, if the patient is not responding, tissue PCR levels. But in our experience, most of our patients do show a good response unless they are severely immunosuppressed. We continue steroid during that period.
See, I'm a bit, I'm always a on-the-spot decision from patient to patient centric. Because the thought in my mind in a situation like this is that the colitis is severe because of CMV or it is because of the flare, or is a combination of the two. So I'm subjective that if the patient is not too bad clinically, then I might as well stick to only CMV treatment and see the response. And if the patient not improving, then I'll add steroids. On the other hand, if the patient's disease is severe that you cannot take a chance or you cannot delay, then possibly I'll continue the both. That's a very subjective feeling, not based on any data here, but that's the way I look at it.
Agreed, sir. I think we need to treat the CMV first in this patient. We know that the steroids are not working. You can continue the steroids. I think switch to oral steroids or reduce the dose of steroids. That is decided on case-to-case basis. But yes, the CMV has to be treated first. I think for response to CMV, I think at least in a week, you should be able to know that the patient is responding or not, depending on response to the fever, response to the pain, and the reduction in the blood frequency. Now, we know that.
Dr. Anurag, I'll have a slightly different opinion. This patient fulfills the criteria for acute severe UC. We have already given IV steroids for 3 to 5 days. And we know that CMV is a common thing in patients who are steroid refractory. And if we just wait for 7 more days, looking for response to antivirals, we are actually losing on time. So for acute severe UC, when it's difficult to differentiate whether it is disease flare or CMV is causing the symptoms, I don't think that we should wait for so long. Usually the response to antivirals comes in 3 to 5 days. So probably we should be looking at earlier decisions rather than waiting for 1 week on antivirals.
I think another important point is we need to take a lot of biopsies to get the CMV positive, because sometimes one of the studies have shown that at least 11 bits of biopsy should be taken to get the CMV positivity. So sometimes our result can be false negative. Even if the endoscopic biopsy is not showing, if there is clinical suspicion, still you can actually give the antivirals.
Yeah.
This is the reason why in the beginning itself I said that the turnaround time for biopsy report and PCR is very important. So acute severe, you see, there's no point doing an immediately a sigmoidoscopy and getting the report after 10 days. So it's very important that these biopsies are marked for rapid turnaround so that we can take this decision earlier.
Right. So when do you suspect CMV? I think when you have large punched out ulcers, there is leukopenia, there is abnormal LFT and mild splenomegaly. The tissue CMV PCR and the IHC is the gold standard. And there is a tricky situation when to choose the CMV treatment over the upgradation of acute severe ulcerative colitis. Now, responders to treatment with positive CMV, no need to further treat for CMV. If there is non-response to treatment with a positive CMV, you can start with the ganciclovir. If there is severe systemic CMV, there is disseminated CMV, you have to stop the immunosuppression and treat with the ganciclovir. Now, this is the algorithm that we have proposed a couple of years ago for all patients of acute severe ulcerative colitis, especially in steroid and thiopurine refractory disease and with deep ulcers and endoscopy. You have to look for the inclusions, look for the tissue PCR, and quantify the IHC positivity and the quantitative PCR. You have to differentiate a low-grade infection where the disease activity is the predominant factor, where you have to increase the immunosuppression. And if it is a high-grade disease, you have to taper the steroids, start the antivirals, and consider stopping thiopurine. Now, the patients, yes, ma'am.
Just once again, I was surprised that this patient's IgM CMV was negative. Usually it is, IgM CMV is positive and these are reactivations of CMV. So I was quite surprised why this patient was negative.
I think we have seen some of the patients where IgM CMV was negative, but the blood CMV PCR had come positive. So the best modality is obviously tissue PCR. I think that is the way that we should diagnose colitis in such patients. Now, in this patient, it was managed with IV ganciclovir. There was some leukopenia on day 5. The WBC count had dropped to 2550. There was initially reduction in the dose and gradually it was halted. Then CBC was subsequently improved and the patient was put on oral valganciclovir. Now, the problem remains. The stool frequency had come down, but it was around 4 to 5 per day with blood in all, even after 10 to 12 days of therapy for CMV. Now, which is the best rescue option in this setting of acute severe ulcerative colitis with a CMV colitis that is on a treatment? Dr. Usha.
Yeah, so in this situation, I think I would not go with cyclosporin or infliximab at this point of time. JAK inhibitor is an option. And surgery, there have been situations where people have done surgery in settings of CMV colitis and found response, but obviously that is not the way to go. So I would go with JAK inhibitors, either tofa or upadacitinib at this juncture, because right now our aim is to control the ASUC, which is creating a problem in the background.
Dr. Arshdeep, which is your go-to option?
I think all are the feasible options. We have to discuss with the patient the pros and cons of each of the therapies. But all are the options. We have to take a decision which has to be shared with the patient.
Yes, I think the patient is a very sick patient and there is a risk of infections like CMV. I think infliximab will be a slightly better drug. But provided that we need more evidence for JAK in patients who have predisposition for infections. But yes, if the patient has low albumin, I think JAK will have an upper hand over infliximab. And if it is a cost content setting like ours, I think JAK will be a good drug. Now, the patient also had dysphagia. This developed after a week of steroids. It was mild symptoms. Endoscopy had esophageal candidiasis. And the patient was already also started on fluconazole for 200 milligram once a day for 2 weeks. I think Dr. Usha and I, we had worked on this aspect regarding the role of candida in acute severe in patients with ulcerative colitis. And we had found that steroids were a big risk factor for esophageal candidiasis. And all those patients who had candida in their stool culture had some response in clinical response and reduction in calprotectin as well. Now, based on the clinical course and the financial constraints, we couldn't give infliximab. And after a mutual discussion, upadacitinib was started, and patient had response to 45 milligram per day. The duration of therapy for Valga and Zirclobir was continued for 21 days, and at discharge after 25 days of hospital stay, patient was in clinical remission. So, how do you choose between tofacitinib and upadacitinib, especially in ulcerative colitis or in acute severe ulcerative colitis per se, Dr. Ajay?
Yes. You can put the next slide there, saying that it's better to go through the table. It's a it's a very subjective decision right now that basically half-life of tofa is like 6 to 8 hours, while the upada is 8 to 14 hours, and a risk of complications. And whether you look at the type of JAK inhibitors where they're effective, there's not much relevant in ulcerative colitis. That's more relevant in Crohn's. Cost today's time, correct me if I'm wrong, upada is slightly more than tofa, and that may be a relative factor. But when it only today morning there's a flash on the American Society of GI Endoscopy review journal. Sorry, it's an American Journal of Gastroenterology publication, which is a 11 studies meta-analysis that when you have a severe UC, the response to infliximab and upada is comparative and better than the tofa and the other biologicals. I think, Anurag, you have gone through that. You will have some percentages there, and that is a faster response and a better and a quicker response, and that is based on the endoscopic severity. They have not taken the entire severity spectrum in that paper. So from that angle, I think possibly, I mean, till today we have been going for tofa, but I think in the times to come, it will be possibly upada which will replace tofa.
I just wanted to add here that in acute severe, you see the 3 to 7 day response with upada is about 84% compared to 54% with tofa. So in this patient with acute severe ulcerative colitis, upada may have an edge over tofa. I agree with what Dr. Ajay has said that right now we still have limited evidence, and this meta-analysis shows that about 2 times better response with upada compared to tofa. So this is a paper which on ASUC is in CGH 2026. So the other thing is that steroid-free remission also is higher with upada compared to tofa, or 65% versus 38%. This is the real life Japanese study. So there's very limited data, but that's why, as Dr. Ajay put it, that right now it is more of gut feeling as to what way it would go, but uh, uh, preliminary evidence is in favor of upadacitinib.
I think selection of JAK is a big query. I think patients with prior anti-TNF failure and acute severe ulcerative colitis, both are the preferred drugs. You can prefer UPA if there is prior TOFA failure, if the patient has been exposed to tofacitinib earlier. If you have suspected Crohn's disease and there is adherence issue also, this is twice daily, UPA is once a day. And you can prefer TOFA if the patient has history of acne and it is a young patient and we have cost constraints. I think Dr. Ajay rightly said that TOFA right now is cheaper. I think the cheapest molecule is 9 rupees per tablet. So TOFA, if it is a long term, if the patient has some cost constraint, TOFA might be a better drug than UPA. Now, this is a setting of acute severe ulcerative colitis, and you are putting a patient on JAK inhibitors, and we are concerned that patient might require a surgery also in a proportion of patients. So, Dr. Arshdeep, what are your thoughts on this?
Yeah, so as the recent meta-analysis has shown that use of JAK inhibitors has actually decreased the short-term colectomy rates. So if we are using JAK inhibitors, we are probably looking at fewer colectomies. And regarding the specific question on use of JAK inhibitors, there has been a single multi-center study from US, which has actually compared tofacitinib and infliximab and the post-operative outcomes. And they found that JAK inhibitors, especially tofacitinib, which they compared, actually had lower rate of complications, including infections and serious infections and wound healing. All three complications were lower with the JAK inhibitors compared to infliximab. So even if you have to use JAK inhibitors for acute severe UC, the outcomes after colectomy are not affected. Rather, they are better than the anti-TNFs.
I think agreed. Tofacitinib is a rapid drug. So if you stop the drug, there's a rapid washout as well. So theoretically also, tofacitinib will have some favorable profile in terms of post-operative risk. And this was the real-world study where they showed that it did not increase the post-operative risk as compared to infliximab. So now the patient was discharged. Patient came back to OPD after 1 month. She was still in clinical remission. Now she has a new problem. She developed acne. So how to go about it, Dr. Partha?
So I think acne and herpes zoster are class-specific adverse events of JAK inhibitors, and which is being reported more with upadacitinib rather than tofacitinib. So I think at this juncture, the patient has achieved clinical remission. I'd also like to see for other parameters like maybe a point of care ultrasound, so whether the radiologically also the patient has responded or not. And if there is radiological response, then I may reduce the dose to 15 milligram as well. But still, if there is, I think, significant activity is there, although this patient is in clinical remission, I may still reduce the dose, but up to 30 milligram rather than straight away going to 15 milligram. But studies have shown that 15 milligram dose has significantly lower acne rates as compared to 45 milligram, because this is dose dependent adverse event, and which the rates are almost less than 1% as compared to 12% with 45 milligrams. So definitely reduce the dose because patient is in clinical remission, but whether to decrease up to 15 or 30, maybe I need need to see other parameters, objective parameters such as ultrasound or fecal calprotectin.
Agreed. I think this was the largest study till date, and they looked into 2,000 patients, and the prevalence of acne was 12.5%. And they turned this term known as JACNE. And as Dr. Partha said, this had a dose-dependent relationship. So the highest prevalence was seen with UPA at up to the tune of 15%, and 45 milligram had high prevalence of acne as compared to 15 milligram. And most of these patients had a median onset time of 47 days, and they did not report any reduction. Majority of the patients were managed on the standard dose, but they definitely required pharmacological intervention in 40% of cases. So the final diagnosis in our patient was acute severe ulcerative colitis, an E2 disease, past therapy of steroids 5-ASA. The first line was steroids, the second line being upadacitinib. CMV colitis, it was treated with ganciclovir. There was drug-induced leukopenia. There was history of UTI and with a complication of colistin-induced AKI. There was esophageal candida, which was treated with fluconazole. There was JAK-induced acne, which was managed with antibiotics. There was anemia, and there was Graves' disease. So if we look into the clinical cascade timeline, there were lots of waves of infections, waves of complications, and we had to tackle with antibiotics, antivirals, and immunosuppression. So to summarize, I think acute severe ulcerative colitis is a distinct entity. It's not the classical as with ulcerative colitis, all other spectrum where you just manage the disease. There is high index of suspicion for CMV colitis in steroid refractory patients. You have to look vigilant for the drug-induced complications as well, because they are the critical patients. You have to navigate the infection versus immunosuppression. The balance is the key. JAK inhibitors are a good drug for resource-limited settings. They are definitely not the best option when the infection-prone patients, but when pushed against the wall, these are a very good treatment options. The long-term outcomes of JAK inhibitors, especially more than 1 year, we still don't have and will definitely require more evidence. So thank you. So I'd like to thank all my panelists for participating in this beautiful case. Thank you.
Very well presented, Anurag. Excellent. Thank you for taking the trouble to highlight such a beautiful case so that we learn from that. One other point which I wanted to make was in a patient who's having UTI and has received several antibiotics, apart from testing for Clostridium difficile at onset, we should again retest them because now they're hospitalized, they're on antibiotic, they're at greater risk. So retesting for C. difficile is also important.
I think, Anurag, congratulations on the case as well, because the number of comorbidities and that the patient is doing well. I think a fantastic discussion. What I'll do is there are a lot of questions which have come. that I'm supposed to summarize how to get upadacitinib into clinical practice. So in 5 minutes, I'll just quickly brush past that, because a lot of questions have come on CMV and what to do. And I think upadacitinib is, for most of the audience, becoming a wonder drug. So I'll just quickly, because most of everything has actually been covered. So my job is very, very simple. On how to integrate. And if you see that it was the era of biologics for 2 decades, and then we had the small molecules. We need to know what are these small molecules. Today, they can be perfectly engineered. So, this is different. So, generics, therefore, are much more stable, because you just follow the Lipinski's rule of 5 and you can perfectly design your small molecule. It has the ability to cross biological barriers, hence not albumin dependent, and has oral bioavailability. The focus is on small molecules, and in India, we have only the JAK inhibitors. The name is after Janus, the two-faced Roman god of beginnings, and I think wonderful beginnings here. So it has JAK1, JAK2, JAK3, and tyrosine kinase. And if you see, specific cytokines and growth factors use specific combination of JAKs. Then the function therefore vary accordingly. JAK inhibition as a therapeutic strategy acts rapidly and, oh, I'm sorry. Acts rapidly by blocking signals of multiple cytokines. By blocking the ATP binding sites of the JAK inhibitors. For ready reckoning, you can see there are a number of selective, non-selective JAK inhibitors, but for us, yes, upadacitinib is more specific towards JAK1. Tofacitinib is the non-selective one. Upadacitinib is now available, and for the audience, and to repeat it, it was approved by FDA for moderate to severe ulcerative colitis 2022 and Crohn's disease 2023. It is fast-acting, oral, effective. The dosage is 45 milligram orally once daily for at least 12 weeks, followed by 15 to 30 milligram depending on the therapeutic response. The options for treatment now has become the big biologics, large molecules, and upadacitinib, the small molecule, particularly where Crohn's disease is involved. So how do you position it? Biologics was there as advanced therapy, and now we have upadacitinib questioning, can I take that place? Which should be used first? And how to optimize treatment. We always think it has to be a balance between efficacy and safety, but cost is also important. What we need to know in practice is comparative efficacy, safety concerns, and of course, in India, accessibility and affordability. So upadacitinib was the first oral drug approved by FDA. It improves endoscopic outcomes in moderate to severe active Crohn's disease. Efficacy has been seen for the treatment of fistulas and fissures. Treatment of refractory pediatric IBD also has now been reported. Not associated with anemia with moderate to severe active ulcerative colitis, and there is a question on this also subsequently. Now, the pivotal studies I'm not going to go into. We need to know you achieve and you accomplish for ulcerative colitis. All results show quick resolution by 4 days of abdominal pain and urgency. Clinical remission good at week 8. endoscopic improvement as well as remission at week 8, definitely much better than placebo. Similarly, for Crohn's disease, it is UEXCEED and UEXCEL. Here again, the results are good, both for clinical remission as well as endoscopic response. For fistulas, as I just mentioned, Professor Columbell's study, there is a tendency that there can be complete resolution of draining perianal fistulas or at least a greater than 50% reduction in draining, and it was significantly higher with upadacitinib. Another interesting area which was not covered in the cases that we discussed today is that tofacitinib can actually, emerging data can actually be used where upadacitinib can be used when tofacitinib does not work. That is again another interesting in the Indian scenario where cost is such a factor, patients on tofacitinib losing response or not responding, upadacitinib can be tried. So again, the next is the safety concerns. A lot of discussion already happened, pulmonary embolism, but usually only at higher doses, was not seen in the phase 2, phase 3 trials, lipid elevations in a dose-related manner. Regarding the side effects, much has been done and discussed about tofacitinib and the use of and the risk of herpes, upadacitinib and the risk of herpes. But if you see and compare, even anti-TNFs actually have an increased risk of infections, including herpes. Vedolizumab perhaps is the safest of the lot, but tofacitinib and the JAK inhibitors fall into the same group. Anti-TNF therapy also increases the risk of herpes zoster. Primary and good evidence has come from rheumatology. And I'll just tell you in summary that if you see the MACE events in the COMPARE study, upadacitinib did not appear to be associated with an elevated risk of MACE compared to adalimumab or adalimumab plus methotrexate. And these are large population studies, larger number of patients. So this is what it has shown in rheumatology. Similarly, malignancies, upadacitinib was not associated with elevated risk of malignancies, excluding non-melanotic skin cancers versus adalimumab plus or minus methotrexate. And again, in the COMPARE study, high CV risk population, upadacitinib did not appear to be associated with elevated risk of venous thromboembolism versus adalimumab. This is very encouraging data from rheumatology because they have been using upadacitinib much earlier than we at gastroenterology. So safety signal is good. Accessibility, affordability, there's no need to mention the convenience of an oral drug versus IV. Low immunogenicity, so there's no need for any concomitant immunosuppressants. That is a big plus. And of course, cost. Majority of our patients have no insurance and are paying out of pockets. In that situation, it is a boon. And I'll tell you, in this study, we found that only 4% of patients with ulcerative colitis ever got advanced therapy in this region of so many 15 countries. So even for Crohn's disease, it was around 13%, much lower than the global average. And perhaps the major reason is cost. So in clinical practice now, even if FDA says JAK inhibitors only after biologics as second line or whichever, in our part of the world, because of the cost benefit, I think JAK inhibitors are poised to stay on top. There will be more and more of top-down therapy as affordability constraints are not there. So the strengths of upadacitinib: rapid onset of action, high efficacy, lack of immunogenicity, oral medication, monotherapy, no need for combination, individually 15, 30, 45, dose adjustment can be done, flexibility in treatment sequence is there, you can use it to biologic experienced, non-experienced, even after TOFA. Possibly a first-line therapy in the Indian context, a treatment bridge to biologics. This you can just take a screenshot of upadacitinib for routine clinical practice, when to avoid pregnancy, lactation, and Pardhu has written this for our journal. It has been accepted for publication. You will see the first edition out, hopefully in August. Avoid live vaccines, GI perforation with NSAIDs. It is also very important to know when to avoid. And I think I'll end with this and we'll go straight to the questions. So I think everybody wants to know, should they switch the biologic that they are using to upadacitinib? Because patients may be affording. If they are in remission, what should they do? And I'll take everybody's panelists' opinion on that. Maybe Partha? You're muted.
I think all these therapies have a therapeutic ceiling, like JAK inhibitors. Even if you change from a biologic to a JAK inhibitor, the problem is the same biologic, they develop antibodies, and the same biologic, the response rates may be lesser. And there is no guarantee that the JAK inhibitors will all work in all the patients. So if the patient is in clinical remission with the biologics, I'm not going to change the therapy unless that is it is not financially possible to continue the medications. And another thing is, if you start the small molecules and then if it is not working, again you have to restart the biologics. Again, you have to go through the entire induction therapy before the maintenance. These are the challenges of suddenly changing the biologics to the small molecules.
So any other comments? Arshdeep?
So not
Usha?
I would not shift from something which is already a winning combination, whatever the patient is getting. So just shifting for the sake of shifting is not a good option. Unless, as Partha suggested, that the patient will discontinue therapy because of cost considerations, then we can consider one of the small molecules.
Because somebody has written that patients are coming and asking, oral drug is now available, so instead of injection, can I shift? So I think in practice, it needs to be explained very well. The other is the question of, the one question has come that if there is a patient of ulcerative colitis, what will be the first choice drug? Should it be between the JAK inhibitors? Should it be upadacitinib or should it be tofacitinib? Vishal?
I mean, I have nothing more to add to what Anurag in his beautiful systematic review has shown, that actually there is not much to choose. For this particular indication, I think both seem to work well. And in fact, the efficacy and even the adverse effects were similar in that systematic review, which has just been published in CGH.
So for acute severe ulcerative colitis, will we still go with tofacitinib because of the data?
I think so. I mean, so we have been using upadacitinib also now, and I think both of them work fine. I mean, if they work, they work.
But okay, there is seems to have an edge over TOFA in terms of its efficacy, onset of action, as well as long-term remission. It does have an edge over TOFA. More data will come in, but I would think that the data is showing Upada to be better than TOFA.
Yeah, for moderate to severe disease, I think we have data where upadacitinib holds the edge over tofacitinib. But for acute severe, you see, we don't have much data for upadacitinib. Even long-term data with tofacitinib, we don't have. So as the systematic review says that for acute sphere UC both are equal. But I think the question was for any patient who was diagnosed with ulcerative colitis rather than acute sphere UC. So a word of caution is recommended that first line for mild to moderate UC still remains 5-ASA. It should not be that we are starting all patients who are diagnosed with ulcerative colitis on advanced therapy. The first line still remains 5-ASA. We have to follow the step up approach for mild to moderate disease, except for acute sphere UC where we have to hit hard at the beginning.
I think using upadacitinib has some mechanistic basis as well, that it is a selective one, so it is acts on the target, whereas JAK inhibitors like tofacitinib is a pan-JAK inhibitor, so the overall effect is thinned out. So I think some mechanistic this thing that upadacitinib may work better than tofacitinib.
I think we have to watch the space on that, but there is a question that if I do have to change, the patient is in remission and can't afford, needs to change, what is the right time and way to change? So say the patient is on infliximab and for remission, so what should be the strategy? I was just wondering, maybe if the patient is in remission, we stop the drug.
We stop the
if
drug
it
and
relapses, then we
that may be best.
So I would tend to kind of, so I have already shifted some patients because of cost reasons. So I come from that space. I would disagree that we wait for a relapse, because relapse can go anyway. I mean, once the cost is the factor, sometimes, they will not be really in, kind of endoscopic remission or deep remission where you truly are considering de-escalation. And we know that even when you de-escalate, I mean, there are so many randomized trials that when you de-escalate and when it is the biologic which is discontinued, the chances of a relapse are fairly high. So I would be very wary of, so the disease was so bad that you had to, I mean, for ulcerative colitis, you had to start an advanced therapy. And I would believe that the biology would not have changed and would probably put on some kind of therapy.
So immediately,
I think that so difficult questions are whether you start on 45 or 30, because the patient is in kind of a remission. When do you start? Let's say you've given an infliximab dose today. Do you start tomorrow? I mean, obviously, there's no data to support it. It is your hunch, what you understand. I would probably, maybe 4 weeks after the last dose of infliximab, I'll certainly start. And I'll probably again start with 45 for some time and then go to 30. This may be, I mean, obviously, there's no data to say this way or that way, but this could be one of the approaches you could take.
I think very valid point that when to restart, because you don't want to combine therapy. This trough level is still persisting. Yeah. Then you are giving the another drug. So I think you have already used infliximab, so you know when the trough level is decreasing. So I think some patients the drug is washed out in 4 weeks, some patients 8 weeks. Based on that, you can reintroduce the newer therapy, advanced therapy. I think.
So maybe after 6 weeks or so. Yeah.
Yeah, I think the audience needs to be informed that symptom response and endoscopic response alone is not sufficient. Histological remission, a very small subset of our patients really manage to achieve. So stopping the biologicals and waiting for a relapse is not an option, and they should be started on an alternative agent.
I suppose it takes about a week for even JAK inhibitors to, respond. And if we are giving the Remicade or the infliximab at every 2-monthly interval, so if you have to switch, maybe after 6 to 7 weeks, maybe, so that by that time it's time for the next dose. But these are all empirical situations that we face. There are a last couple of questions because there are a lot of.
I'll just like to quickly, say that for other advanced therapies, whenever there is switch, there is already, suggestion that you don't really need to wait for the half-lives and, things to disappear. So, I mean, just I'm using a corollary that it is okay that we don't want to, bombard with a lot of immunosuppression, but it's fairly okay to kind of start after 4 weeks or so.
But still the message should be that if a patient is on remission on a particular drug, we should tend not to change the therapy.
Absolutely. Absolutely.
I completely agree. I think the message should be that if the patient is stable on biologics, and they all come with a half-life, every drug, there is a secondary loss of response. So it doesn't make sense starting all the drugs and finishing by the first few years and then
responded very well to difficult Crohn's, and then but I had to stop the drug and give a gap of about 1.5 months, and then restarted at a smaller dose, 15 mg instead of 45. I don't know what, I mean, I'm not aware of any guidelines to do that, but I wanted, because she responded so well, I didn't want to deprive her complete benefit of upadacitinib, so that's what I did.
Any other comments on that? I think it is true you have to decide this on a case-to-case basis. There are some recent studies which are showing that anemia is not consistent with upadacitinib, but the pivotal study showed it. So I think we have to keep that in mind. The other simple question, but I think it's a valid question for routine practice, that is, if you are using upadacitinib early for ulcerative colitis, then will you stop the mesalamines and just keep the patient only a single day dose of upadacitinib?
Yes, I think there are enough data to suggest that whenever you are starting biologics, for small molecules, you usually stop the 5-ASAs. But in this case, sometimes in few patients, even after starting upadacitinib, especially in ulcerative colitis, they have persistent proctitis. So in those patients, I still to continue to the suppositories in these patients. Yeah.
I think, it's important that a checkup is done, a colonoscopy is done before any such decision is taken, and the winning combination should always stay. But stopping mesalamines, we can't tell as a blanket, can we? Dr. Usha, what do you think?
I would tend to continue mesalamine with Upada, though there isn't much data on this area, but I think it is something which is a safer option. After all, upadacitinib is an immunosuppressant, so continuing an anti-inflammatory with upadacitinib may be a better option. And as Partha was saying, a lot of patients with ulcerative colitis, when you continue rectal therapies, that pushes them more into remission. So I don't think we should stop rectal 5-ASA in whatever form that we are giving.
I think it has to be again decided on a case-to-case basis, but you should bring down, once the patient is in remission, try to optimize to the lowest dose that is possible. And I suppose the word of caution should be that what Dr. Usha just mentioned, that these are anyway immunosuppressants. They do have side effects. They are not safe in pregnancy. They are not safe in this. So I think that is a good suggestion. So I think we've had a fantastic discussion and on upadacitinib, and I see the excitement that at least we have now something for all patients, because cost factor is taken care of, and also the convenience of an oral drug. And with pediatric cases also increasing, I think we will see more and more usage, but we need more data from India. And I can see Arshdeep smiling, I can see Partha smiling, Anurag, Dr. Vishal. I think we will be seeing a lot more of that. Before I close, of course, I want to thank all of you for participating on a Friday evening. I think it made it wonderful. All the panelists, they're all leaders, stalwarts in IBD in India, definitely. And I would also like to thank Dr. Reddy Labs for providing an educational grant and helping us to organize this webinar. So at the back end, of course, we have our AIG team with all the YouTube sending questions, moderating and managing. Mr. Satya leading from behind. And thank you, Mr. Satya, Mr. Mohan, and all at the back end. Thank you so much. Good night.
Thank
Good
you.
night. Thank you. Very good cases, Dr. Vishal and Dr. It was educative. Thank you.
Thank you. Thank you, ma'am.
Thank you. Thank you. Fantastic cases. Both of you, awesome cases.